fast. We have a 61-year-old man with opioid use disorder and uric end-stage renal on dialysis and chronic untreated hep C. He's admitted with fevers and night sweats for 2 weeks and found to have MSSA bacteremia. On exam, he's got diffuse palpable purpura on his extremities, altered mentation, and diffuse myoclonic jerks. So you're concerned for vasculitis or septic emboli to the brain. A CT of the brain is unrevealing. What's the best next step in imaging? So these are your answer choices, and we're gonna switch on over to see our polls, and we have a pretty wide distribution. Most people opting for MRI brain with contrast after discussing with radiology, and then some people saying maybe just forego contrast altogether. All right, excellent. So we've got a wide spread. Let's talk about the answer. So I'm going to say the answer is C. Most of you are correct, and it's always a great choice to choose something after discussing with radiology is always a good option when you're taking a test. All right, so just as a quick review, the difference between CT and MRI. In CT, we use iodinated contrast, and there the risk, among many others, is contrast nephropathy, which is actually a real diagnosis, despite what many of you may have heard in the recent literature. It can still happen, but it's often confounded by other common causes of AKI, which leads to some confusion. On the other hand, MRIs generally use gadolinium-based contrast, and here the real risk is this rare diagnosis of nephrogenic systemic fibrosis, or NSF. It's extremely rare, but it is pretty terrifying. So let's do a quick review of the types of gadolinium contrast. I'm only including these here because it's important to know there are 2 different groups. Group 1 are the older agents, and group 2 are the newer agents. The ones in red that I've highlighted are the ones that we use at the VA. Previously, we used gadovarcitamide, and now we use gadobutrol. This is important because the risk of NSF is higher with a group 1 agent versus a group 2 type of contrast. So what is nephrogenic systemic fibrosis? It's a very rare disease that presents with scleroderma-like fibrosis of various organs. Usually the skin and muscle are affected, and then internal organs can be affected as well. It tends to happen after patients are exposed to gadolinium contrast when they have advanced CKD, and is especially at high risk when their GFR is less than 30. As we just talked about, it also changes with the type of contrast, so type 1 agents being higher risk. So this is the typical appearance of NSF. You see these darkened, kind of thickened areas or patches of skin, or kind of woody induration. That's when you should suspect the diagnosis. The diagnosis is hard to make because the symptoms can arise days to months after GAD exposure, so it's a long time afterward, and the confirmation is with a skin biopsy. And then lastly, treatment is pretty difficult. So a lot of things have been tried, like steroids, immunotherapy, plasmapheresis, and ultraviolet, but they have not been shown to be that effective. And actually the best thing you can do is early physical therapy, and renal transplant has been shown to have some reversibility of the disease. So because it's such a scary disease, you have to now weigh the risks and benefits of giving GAD contrast in somebody with advanced CKD. So on one hand, there's the risk of irreversible fibrosis, lifelong debility and death, and then maybe the fact that we don't recognize cases since the spectrum of symptoms is so difficult to recognize. On the other hand, it's an extremely rare disease, and it's less of a risk, especially now that we use mostly group 2 gadolinium agents at the doses that you would give for a routine diagnostic MRI. And if you don't use contrast, you might actually prevent or delay diagnosis for somebody who has a severe illness. So all that said, the American College of Radiology in 2020 put forth this kind of vaguely worded guideline that said that because the risk of NSF is so low now with our newer gadolinium-based contrasts, the harm of delaying the MRI or withholding an MRI with contrast might be greater than the actual risk of a patient developing NSF. So it's worth proceeding in most clinical situations. Very hedgy. So in summary, remember that you can see all of our slides at bit.ly/imfastfacts, but NSF is the scleroderma-like fibrosis of skin and the other organs. It tends to happen days to months after GAD exposure. The diagnosis is made with skin biopsy, and the only treatment that's shown to be truly effective is early physical therapy and renal transplantation. The risk is very low. The overall rate is reported to be less than 0.5%. It is increased risk with group 1 agents, so older gadolinium agents, and increased risk if your GFR is less than 30. So what should you do? You should always weigh the risks and benefits of giving a contrast with MRI. If your GFR is less than 30, discuss alternate agents with radiology. There may, in some centers, be options that are non-gadolinium based, like ferriomoxetol. And always engage the patient in shared decision making. That's all. Questions? I see one in the chat. Does anyone know if NSF happens in the setting of AKI or just CKD and ESRD? That's a great question, Nico. I think it's all case report based. There's only been a handful of cases reported over time. I think for the most part, they happen in end-stage renal disease. Other questions? Yes, Dr. Patel wrote, we have ferriomoxetol at the VA. So we have it at UCLA at the VA. While we have it, it's mostly restricted to cardiac MRI. I have not successfully used it for non-cardiac MRIs, but I still think it's worth calling radiology just to ask what your options are, and they can talk you through the risks and benefits as well. All right. Great. Thanks everybody for joining us.